Welcome to StudyNeuro. In this presentation, we will examine papillary craniopharyngioma, focusing on its clinical features, magnetic resonance imaging findings, histopathology, molecular biology, and management. Let's get started. By the end of this presentation, you should understand who typically develops papillary craniopharyngioma and where it usually arises in the sellar and suprasellar region. You should also be able to recognize its common clinical presentation and identify the important features on magnetic resonance imaging. These are the basics. We will then examine its characteristic microscopic appearance and the significance of the BRAF proto-oncogene valine 600 to glutamic acid mutation, which is strongly associated with papillary craniopharyngioma and has important treatment implications. This molecular feature helps distinguish it from adamantinomatous craniopharyngioma. The presentation will also cover current principles of treatment, including surgery, radiotherapy, and targeted treatment directed at the BRAF proto-oncogene pathway, while considering how tumor location and involvement of nearby structures influence management decisions. Treatment must remain individualized. Finally, we will review tumor recurrence and the need for long-term follow-up because successful initial treatment does not always eliminate the risk of future disease or lasting functional problems. For more high-yield neuroscience education and clinical pearls, join the StudyNeuro community on YouTube, Facebook, TikTok, Instagram, and X. Follow StudyNeuro for more medical learning content. Craniopharyngiomas are rare epithelial tumors that arise in the sellar and suprasellar region, close to structures involved in vision and endocrine function. Two principal histological types are recognized. They are biologically distinct. Papillary craniopharyngioma is less common and occurs predominantly in adults. It is typically a solid, well-circumscribed tumor, which means its margins are usually clearly defined from the surrounding tissue. Compared with adamantinomatous craniopharyngioma, papillary craniopharyngioma usually has little or no calcification and contains fewer cystic areas. Wet keratin is not a feature. Instead, it is characteristically associated with the BRAF proto-oncogene valine 600 to glutamic acid mutation, an important molecular finding that helps confirm the tumor type and guide treatment. Papillary craniopharyngioma is predominantly a tumor of adults and is uncommon in children. It represents a smaller proportion of all craniopharyngiomas, with most patients presenting during middle adulthood. There is no consistent strong preference for either sex. Age matters. An adult with a solid suprasellar mass and little or no calcification should raise suspicion for papillary craniopharyngioma, particularly when the imaging appearance fits the typical pattern. However, age and imaging findings can only suggest the diagnosis. Definitive identification requires correlation with histopathology and molecular findings, especially detection of the characteristic BRAF proto-oncogene valine 600 to glutamic acid mutation. Papillary craniopharyngioma typically arises in the suprasellar region, often involving the pituitary stalk and extending toward the hypothalamus or floor of the third ventricle. Its location places it close to critical structures. Anatomy matters. As the tumor grows, it may extend upward into the third ventricle, downward toward the sella, or laterally toward the optic apparatus and nearby structures. These growth patterns help determine the extent of surgical exposure and the potential risks of treatment. The optic nerves and optic chiasm may be affected, while the pituitary gland, pituitary stalk, and hypothalamus are also vulnerable because they lie next to the tumor. Major cerebral vessels can be involved as well, making careful anatomical assessment essential before surgery. The main surgical challenge is the tumor's close relationship with the hypothalamus, optic pathways, and pituitary stalk. Attempting complete removal may therefore carry significant functional risks, so treatment must balance tumor control with preservation of neurological and endocrine function. The clinical features of papillary craniopharyngioma mainly result from compression or invasion of nearby structures. Because the tumor develops close to the visual and endocrine pathways, symptoms often reflect the structures that are affected. Location determines presentation. Visual symptoms may develop when the tumor compresses the optic pathways, causing progressive visual loss, reduced visual acuity, or defects in the visual field. The visual decline can be gradual. early assessment is important. Endocrine dysfunction occurs when the tumor affects the pituitary gland or pituitary stalk, leading to hormone deficiencies such as growth hormone deficiency, central hypothyroidism, or impaired gonadal function. Adrenal insufficiency and diabetes insipidus may also occur, while stalk compression can increase prolactin levels. Neurological symptoms may include headache, particularly with larger tumors, while involvement of nearby brain structures can affect memory, cognition, or behavior. These changes may be subtle at first. Large tumors can obstruct normal cerebral spinal fluid circulation and produce hydrocephalus, which raises pressure within the skull and may cause worsening headache, nausea, vomiting, or papilledema. Raised intracranial pressure requires prompt attention. Papillary craniopharyngioma can disrupt the hypothalamic pituitary axis, affecting hormone production and the body's regulation of several important functions. The endocrine effects can be significant. Careful assessment is essential. Pituitary dysfunction may cause central hypothyroidism, adrenocorticotropic hormone deficiency, or gonadotropin deficiency, while growth hormone deficiency can affect growth and body composition. Compression of the pituitary stalk may also increase prolactin levels, and damage to water-regulating pathways can cause diabetes insipidus. When the hypothalamus is involved, patients may develop excessive weight gain or obesity because appetite and energy regulation are disturbed. Sleep problems, cognitive impairment, behavioral changes, and abnormalities of autonomic function can also occur when hypothalamic pathways are affected. A complete endocrine assessment should therefore be performed before treatment and repeated during long-term follow-up because hormone deficiencies may persist or develop after surgery or other treatment. Long-term monitoring matters. Computed tomography can provide useful structural information in papillary craniopharyngioma, particularly when assessing calcification and the surrounding bone. The tumor is often well-defined. Its appearance is usually solid. On computed tomography, papillary craniopharyngioma typically appears as a predominantly solid suprasellar mass with strong or uneven contrast enhancement. Calcification is usually minimal or absent, although small cystic areas may occur, and larger tumors can extend into the third ventricle. Computed tomography also helps define the sella and surrounding bone, while showing hydrocephalus and the tumor's relationship to nearby structures. This information can support surgical planning. A useful imaging clue is that papillary craniopharyngioma is generally more solid and less calcified than adamantinomatous craniopharyngioma. Imaging can suggest the diagnosis, but it does not establish the tumor type on its own. Magnetic resonance imaging is the main imaging method for assessing papillary craniopharyngioma because it shows tumor size and extension while defining its relationship with nearby critical structures. This is essential for treatment planning. The tumor is usually solid and well circumscribed, meaning its margins are relatively clear. It commonly appears iso-intense or hypo-intense on T1 weighted imaging, while its appearance on T2 weighted imaging can vary. After gadolinium administration, strong enhancement is typical. Magnetic resonance imaging should also carefully show the optic chiasm, hypothalamus, and pituitary stalk, because involvement of these structures can affect vision and endocrine function. The third ventricle and major blood vessels also require close assessment. Finally, imaging should determine whether the tumor has obstructed cerebrospinal fluid pathways and caused hydrocephalus. These anatomical relationships are particularly important when considering surgical treatment. Anatomy guides management. Papillary craniopharyngioma has a distinctive microscopic appearance that helps separate it from the adamantinomatous type. The tumor typically forms papillary structures with layers of relatively uniform squamous epithelial cells arranged around fibrovascular cores. The pattern is characteristic. The tumor usually has well-defined margins and lacks the complex epithelial architecture seen in adamantinomatous craniopharyngioma. Importantly, wet keratin and stellate reticulum are generally absent, while prominent peripheral palisading and extensive calcification are not typical features. Histological examination therefore shows a papillary squamous epithelial tumor with a relatively uniform appearance, providing an important diagnostic basis for distinguishing papillary craniopharyngioma from adamantinomatous craniopharyngioma. Pathology remains central to diagnosis. The molecular hallmark of papillary craniopharyngioma is the BRAF proto-oncogene valine 600 to glutamic acid mutation. The valine 600 to glutamic acid mutation causes persistent activation of the BRAF signaling, even without the normal signals that would control it. This abnormal activity promotes cellular proliferation and contributes to tumor development. The effect is important. This mutation has practical clinical value because it can support the diagnosis and clearly separates papillary craniopharyngioma biologically from adamantinomatous craniopharyngioma. More importantly, it provides a potential target for treatment with drugs that inhibit the BRAF and mitogen-activated protein kinase pathways. In simple terms, the BRAF proto-oncogene valine 600 to glutamic acid mutation keeps the mitogen-activated protein kinase pathway active, promoting the development and growth of papillary craniopharyngioma. Papillary and adamantinomatous craniopharyngiomas are distinct tumor types with important differences in age, appearance, histopathology, and molecular biology. Papillary craniopharyngioma mainly affects adults and is usually solid with little calcification. It characteristically carries the BRAF proto-oncogene valine 600 to glutamic acid mutation. Adamantinomatous craniopharyngioma occurs more often in children and commonly has cystic components and calcification. It is associated with catenin beta-1 gene mutations and nuclear accumulation of beta-catenin with wet keratin as a characteristic histopathological feature. The key distinction is simple. Papillary craniopharyngioma is typically an adult solid tumor with the BRAF proto-oncogene valine 600 to glutamic acid mutation, whereas adamantinomatous craniopharyngioma is often cystic and calcified with catenin beta-1 and beta-catenin pathway abnormalities. Management of papillary craniopharyngioma requires an individualized, multidisciplinary approach. Treatment is guided by the tumor's size and location, its relationship with the hypothalamus and visual pathways, and the patient's previous treatment and molecular findings. Each case is different. Surgery aims to achieve maximal safe tumor removal, but the approach depends on the tumor's anatomy and extension. An endoscopic endonasal approach may suit selected lesions, while a transcranial approach remains appropriate in other anatomical situations. Complete removal is not always the safest option. Aggressive surgery can damage the hypothalamus, visual pathways, or pituitary function, leading to serious long-term problems. Protecting function, therefore, remains a central goal. Radiotherapy may be used when residual tumor remains, when the disease recurs, or when complete safe removal is unlikely to be achieved. It provides another way to control tumor growth. For tumors carrying the BRAF proto-oncogene valine 600 to glutamic acid mutation, targeted treatment directed against BRAF, often combined with mitogen-activated protein kinase inhibition, is an important option, particularly for recurrent or difficult-to-resect disease. Molecular testing can therefore influence treatment. Papillary craniopharyngioma can cause complications from the tumor itself or from its treatment. Tumor-related problems may develop when the lesion affects nearby structures responsible for vision, hormone regulation, and cerebrospinal fluid circulation. These effects can be lasting. patients may develop visual impairment or reduced pituitary function, while involvement of water-regulating pathways can cause diabetes insipidus. Larger tumors may also obstruct cerebrospinal fluid flow and produce hydrocephalus, and hypothalamic involvement can lead to cognitive or other functional problems. Treatment can create additional risks, particularly when surgery involves structures next to the tumor. These may include cerebrospinal fluid leakage, vascular injury, new hormone deficiencies, visual deterioration, or hypothalamic injury, while radiotherapy can produce delayed treatment-related complications. Because recurrence can occur, patients require long-term surveillance with appropriate imaging and clinical assessment. Follow-up should also monitor visual and endocrine function, especially when treatment has affected critical structures. Long-term care matters. Long-term follow-up is essential after treatment for papillary craniopharyngioma because recurrence can occur, and some neurological, visual, or endocrine problems may appear or persist over time. Treatment does not end surveillance. Regular magnetic resonance imaging helps detect recurrent or residual tumor, while endocrine and visual assessments identify changes that may require treatment. Neurological, cognitive, and functional assessments are also important, particularly when the tumor or treatment has affected the hypothalamus or nearby brain structures. Even when initial treatment appears successful, patients should continue long-term surveillance. Early detection of recurrence or delayed complications allows timely intervention and better preservation of function. In summary, papillary craniopharyngioma is an adult predominant tumor that usually presents as a solid suprasellar mass with little or no calcification. Visual problems, hormonal disturbances, and headache are common. Histologically, it shows papillary structures with fibrovascular cores and squamous epithelium. Its defining feature is the BRAF V600E mutation, which activates the mitogen-activated protein kinase pathway and distinguishes it from adamantinomatous craniopharyngioma. Management aims to control the tumor while preserving neurological, visual, endocrine, and hypothalamic function. For selected BRAF V600E positive tumors, targeted BRAF and MEK therapy is an important option. Long-term, multidisciplinary follow-up remains essential. Join StudyNeuro for high-yield neuroscience education and clinical pearls. Like, comment, share, and subscribe. Thanks for watching, and stay tuned for more.